In 1902, Sir James Mackenzie published his classical work entitled The Study of the Pulse, Arterial, Venous, and Hepatic, and the Movements of the Heart. This superb book can still be obtained and makes exciting reading. His investigations were made chiefly by means of the clinical polygraph. A cup-shaped receiver was placed over the pulsating vein and connected pneumatically by way of a rubber tube to a tambour. To the membrane of this, a lever was attached. In Mackenzie's original instrument, the lever marked smoked paper covering a revolving drum. But in this instrument, modified by Sir Thomas Lewis, the lever carries a pen which writes on smooth white paper. The polygraph has several drawbacks, including time lag due to air transmission, overshooting due to the mechanical inertia of amplifying levers, and the primitive method of recording. In modern instruments developed from the polygraph, the receiver is usually a carbon microphone. Electrical transmission eliminates time lag. Thermionic valves provide suitable amplification, and the recording systems are similar to those used for electrocardiography. The phlebogram may be timed against a simultaneous arteriogram and electrocardiogram, as shown here on the Sanborn Polyviso. As a matter of fact, a phonocardiogram probably makes a better reference tracing. The jugular pulse consists essentially of four main waves: A, X, V, and Y. A and V being crests, registering high pressure, X and Y being troughs or periods of low pressure. The A wave corresponds to right atrial systole. A fifth positive wave, C, may interrupt the X descent. The X descent begins with atrial relaxation and is augmented during the earlier part of ventricular systole by displacement of the floor of the atrioventricular septum towards the apex of the heart, creating a negative pressure within the atria. The venous pressure rises later during ventricular systole to form the V wave, because at this time outflow from the atria is temporarily obstructed. The Y descent, or the downslope of V, begins as soon as the tricuspid valve opens, when right atrial and ventricular pressures equalize rapidly and fall together to the trough Y, after which they rise again before the onset of the next atrial contraction. The nature of the C wave proper is controversial. The large C wave recorded in the jugular phlebogram, however, is the carotid pulse itself, as shown by Mackenzie. No wave of similar amplitude and timing is seen in right atrial pressure tracings. While taking full advantage of modern instrumental techniques, it must be emphasized that accurate analysis of the waveform of the jugular pulse and reasonably precise measurement of the amplitude of each individual wave is usually possible at the bedside. The patient should be placed supine if the pressure is below sternal angle level, or propped up if the pressure is raised, the correct position being that which favors maximum jugular pulsation. The most readily inspected pulsation is that of the internal jugular vein. With normal rhythm, there are two main waves: the A wave of atrial systole, the V wave of ventricular systole, and two troughs, X and Y, per cardiac cycle. The movement is soft, diffuse, undulant, and normally impalpable. When timed against the carotid pulse, only the first trough X appears to coincide with systole. The A wave precedes it, the V peak is appreciably later, and Y is clearly diastolic. You can see the arterial pulse here clearly by the light reflection on the red spot. The venous pressure rises on expiration and falls with inspiration, passively following the changes in intrathoracic pressure.